Welcome to the Deep Dive, where we take complex stacks of articles, research papers, and clinical notes and distill them into the critical insights you need to know. Today, we're navigating what is maybe the most common, yet surprisingly complex, prescription intersection in all of modern medicine, the co-prescription of statins and anticoagulants.
It's a colossal topic, it really is, and it's one with direct and often life-altering stakes for millions of people around the world. I mean, we're just so deep in the world of polypharmacy and cardiovascular care. You have patients depending on statins, the HNG-CoA reductase inhibitors, to manage their cholesterol, and at the same time, they're relying on these powerful anticoagulants, whether it's an old-school drug like warfarin or the newer DOACs, to prevent, catastrophic blood clots.
And that's the fundamental tension, right? That's what we're here to talk about. Because statins aren't just cholesterol drugs, not by a long shot. We know they have these profound non-cholesterol lowering effects, what pharmacologists call pleiotropic effects, that directly touch the entire delicate clotting cascade. And meanwhile, both of these drug classes often share the exact same metabolic pathways in the liver. It just sets up this incredibly complex risk matrix.
That's absolutely right. And our mission today is to cut through some of that conflicting data and clarify what the true safety profile is. We really need to go beyond the basics. We're going to get into the strict precautions you need when you combine statins with traditional vitamin K antagonists like warfarin. We'll look at the specific, subtle molecular mechanisms, even genetic variants, that drive an individual's risk. And then we'll see if the newer DOACs face those same challenges. And I think this is the most exciting part, explore the surprising protective secret life of statins.
Okay, let's do it. Let's unpack all this dense material, starting with the original agent, the cornerstone of anticoagulation for decades, warfarin and statins. So let's start with the big picture clinical verdict. If a patient is stable on warfarin, they need a statin. Is that combination inherently dangerous, or is this something that's manageable?
The clinical verdict is, well, it's overwhelmingly reassuring, but with a major, major caveat. The consensus from systematic reviews from large cohort studies is that low-dose statins are generally safe to use alongside warfarin. That combination is fine if it's clinically indicated. The caveat, however, and this is the non-negotiable part, is that this safety is absolutely conditional upon mandatory enhanced monitoring of the patient's INR.
INR, the International Normalized Ratio.
Right. You just cannot initiate this combination and then rely on routine, once-a-month monitoring. It's not enough.
Okay, so help us understand why that mandatory monitoring is so crucial. What's the actual confirmed magnitude of this interaction? Why is it such a problem, even if it gets described as modest?
It's consistent and it's quantifiable. So statins, especially ones like atorvastatin and simvastatin, they modestly increase the mean INR by approximately 0.3 points. Now, when a patient hears 0.3, it sounds tiny, right? It's small in absolute terms. And for a patient who's really stable, say their baseline INR is 2.0, right in the sweet spot of the 2.0 to 3.0 therapeutic range, a 0.3 increase just pushes them to 2.3. Still safe.
But the clinical risk isn't measured in the middle ground, is it? It's all about the edges, where patients are already getting close to that danger zone.
Precisely. That small shift creates a massive proportional jump in risk at the top end. While the overall mean increase is modest, the data confirms it dramatically increases the proportion of patients whose INR rises above the therapeutic ceiling of 3.0. So before a statin, you might have, say, 8% of your stable warfarin patients with an INR over 3.0. Once you introduce that statin, that percentage can almost double, up to about 15%.
Wow. A near doubling of patients whose blood is suddenly too thin.
Exactly. And that is why vigilant, structured monitoring is absolutely non-negotiable.
And this interaction, it's not something that happens instantly. It's more of a slow burn, which I guess makes the timing of those checks so important. What's the key timeline that clinicians really need to be aware of?
This is one of the most important clinical details. We consistently see from cohort studies, a lot of the big Scandinavian register data, that the peak INR elevation, the point of maximum risk, occurs around 4 weeks after the statin is initiated. It doesn't happen on day 2 or day 7. It's a month out.
A month. Why the delay? That suggests it's not just, immediate competition for an enzyme or something.
That's a great question, and it really hints at the complexity of the body's response. I mean, enzyme inhibition is definitely a factor, but some researchers speculate that the delayed peak lines up with the time frame when cholesterol levels are finally stabilizing, and the statin's downstream pleiotropic effects, which we'll talk about later, are really kicking in. So it suggests the body is adjusting to a major metabolic change, and that adjustment phase is where the instability peaks. But whatever the reason, that 4-week mark is the bullseye for risk.
Okay, so let's translate that into that mandatory monitoring protocol you mentioned, the early warning system. What are the specific checkpoints that absolutely have to be hit to keep a patient safe?
Okay, so given that risk profile, the protocol is highly specific. First, INR must be checked within 1 week of starting the statin.
1 week. Why so early if the peak is at 4 weeks?
Because that's your critical early detection window. You have to identify the patients who are rapid idiosyncratic responders, the ones who, for whatever reason, have a much faster, steeper rise in their INR. If you miss that 1 week check, you miss the chance to intervene early with those patients.
Okay, so 1 week for the rapid responders. And then to catch that peak.
Then you absolutely must repeat it at 4 weeks. Missing the 1 week check, you risk missing the rapid responders. Missing the 4 week check, you risk missing the majority of patients whose INR will peak. I mean, inadequate monitoring frequency is one of the single most cited pitfalls in managing this combination. It's so important that for Simvastatin, the FDA label itself explicitly requires an INR before starting and monitoring frequently until it's stable.
Okay, so the protocol flags an elevated INR. What's the action plan? What's the immediate, pragmatic dose adjustment strategy?
So the strategy depends on just how high it is. If the INR is moderately elevated, so between 3.0 and 5.0, the standard action is to withhold exactly 1 dose of warfarin. Think of it like hitting a soft reset. Then you resume, but at a visibly lower maintenance dose once you confirm the INR has dropped back into range.
And what if it's dangerously high, say above 5.0?
Right. If the INR is between 5.0 and 9.0, that's a significantly elevated risk of major bleeding. You have to suspend 1 to 2 warfarin doses completely, no question. And if that patient has any other high bleeding risk factors, maybe a history of ulcers, recent surgery, you have to consider giving a small dose of oral vitamin K, usually between 1.0 and 2.5 milligrams. It's a proactive move to speed up the reversal of that anticoagulation effect.
And the research backs this up, that you actually need to cut the dose long term.
It does. Clinical research confirms successful management often requires an actual reduction in the warfarin maintenance dose after you start the statin.
That clinical guidance seems robust, but it's based on these huge population studies. Can you pull out some specific data points from the real world that reinforce this? Because that range you mentioned, 0.15 to 0.65, that seems pretty wide.
Yeah, that variation just highlights the biological reality, right? No 2 patients are going to respond the exact same way. A systematic review confirms this general trend toward an increased anticoagulant effect. The range from 0.15 to 0.65, that just reflects differences in the patient populations, the specific statins being used, and how they measured it.
So anchor that for us with a couple of examples.
Sure. So take the big register-based cohort study from Sweden. Over 5,600 patients, all stable on warfarin. When they introduced Simvastatin, they saw the mean INR go from 2.43 at baseline up to 2.58 after 4 weeks. That's a rise of 0.15 points. So that's on the lower end, showing in a well-managed population the interaction can be pretty modest. But then you contrast that with a large Danish cohort, about 1,300 patients, which showed a slightly higher increase from 2.40 up to 2.71. That's an increase of 0.31 points, which is right on that average we talked about. And both studies crucially confirmed that 4-week peak.
Did any of those cohort studies suggest that using a higher dose of statin makes the interaction worse?
That's a great question. And interestingly, the data suggests that within the typical prescribed range, the dose might not be the main driver. One study compared high-dose Simvastatin, over 40 milligrams, and low-dose, less than 40, and they found remarkably similar INR increases, 0.33 versus 0.29. So it reinforces this idea that the interaction is systemic. You might hit a dose saturation point pretty early on, which means just prescribing the minimum effective dose doesn't get you out of having to monitor.
And finally, warfarin isn't the only VKA out there. What about common alternatives like fenprocumin or acinocumarol?
The patterns hold true. It doesn't matter which VKA you're using. Patients on fenprocumin who started a statin saw a minor mean INR increase of about 0.1. But crucially, they needed, on average, a 3% dose reduction after 12 weeks. And acinocumarol users needed a 2% dose reduction. The message is just consistent across the board. Statins slightly potentiate the effect. You need to tweak the dose, and you need to monitor closely.
That provides a really exhaustive clinical framework for managing the VKA risk. But now we have to move past just observing it and ask, why is this happening? What is the molecular competition that's driving all of this?
Right, and this is where we have to dive deep into the micromechanisms, because the answer to why is not simple at all. To solve the mystery of why some patients have their INR go all over the place and others barely budge, we have to look inside the engine, right down to the molecular shape of the drugs. We've identified 3 distinct ways statins enhance the effect of warfarin.
Okay, let's go through them.
The first one is simple competition, protein displacement. So, warfarin, when it gets absorbed, it rides through your bloodstream mostly bound to plasma proteins. Only a tiny fraction, the unbound fraction, is actually free to go to the liver and do its job. But when you introduce a statin, the statin competes for those exact same protein-binding sites.
Ah, so it's like a crowded bus. The statin gets on and pushes the warfarin off its seat.
That's the perfect analogy. It displaces the warfarin, and this dramatically, if temporarily, increases the concentration of that unbound active warfarin floating around in the blood. More active agent means a higher anticoagulant effect, which you see as a higher INR.
That makes perfect sense. Okay, now let's get into the metabolic engine itself, the cytochrome P450 system. What are the second and third pathways?
The next 2 are all about metabolism. Warfarin is a mix of 2 mirror image molecules, R-warfarin and S-warfarin, and this is critical. S-warfarin is 3 to 5 times more potent than R-warfarin, so that means the enzyme responsible for clearing S-warfarin is the most important one for controlling the drug's effect, and that enzyme is CYP2C9.
So if a statin messes with that specific enzyme, CYP2C9, then the really potent version of warfarin sticks around longer and the risk goes way up.
Precisely. The second major mechanism is general CYP3A4 inhibition. Statins like atorvastatin, rosuvastatin, simvastatin. They inhibit that pathway, slowing down the breakdown of the weaker R-warfarin. But the third mechanism is the specific and more problematic CYP2C9 inhibition. And this is why Fluvastatin, in particular, gets a red flag. It's really good at targeting and inhibiting this pathway, directly slowing the breakdown of that super potent S-warfarin.
That distinction, inhibiting the metabolism of the most potent isomer, it immediately tells us that assuming all statins are the same is a huge mistake. So let's be explicit. Which statin should be avoided and which are the preferred options for someone on a VKA?
Yeah, you have to be extremely granular here. The big red flag is Fluvastatin. Because of that problematic CYP2C9 inhibition, it really should be avoided if you have alternatives. Conversely, the American Heart Association specifically recommends atorvastatin. It's been observed to have a minimal INR impact in clinical practice, making it a preferred choice. Another really excellent option is pitavastatin, especially at the 4 milligram dose. Studies show it doesn't appreciably increase INR levels, so it's got a much cleaner profile in this context.
Okay, let's get even more technical, because the sources pointed out something really counterintuitive about the statin drugs themselves. The difference between their acid forms and their lactone forms. Why does that chemical difference matter?
This is a remarkable nuance. So statins are usually given either as a prodrug, that's the lactone form, or directly as the active acid form. The lactone form is pretty much inactive until your body converts it into the active acid form. So researchers wanted to know which of these 2 forms is the stronger inhibitor of S-warfarin metabolism via CYP2C9.
And what was the surprising finding?
For the vast majority of statins they tested, atorvastatin, lovastatin, pitavastatin, pravastatin, rosuvastatin, and simvastatin, it was the pharmacologically inactive lactone forms that were more potent inhibitors of CYP2C9 than their own active acid forms.
Wait, hold on. So the inactive precursor chemical that's just floating around is actually better at clogging up the enzyme that breaks down the most potent anticoagulant. That defies logic. Why would the inactive form cause more trouble?
It all comes down to the highly specific nature of enzyme binding pockets. The lactone form, because of its slightly different 3D shape, might just fit better into the CYP2C9 binding pocket. It's a better key for that lock. It effectively clogs the enzyme more efficiently. So the drug interaction doesn't just depend on the main active medicine, but on the precursor too.
Was that true for every single statin?
There was one major exception. Fluvastatin. It was the only statin where the acid form showed stronger inhibition than the lactone form. And this just reinforces why fluvastatin is so high risk. Both forms are actively contributing to that inhibition, leading to maximum risk.
That is a level of detail I don't think most people ever consider. But there's one more layer of complexity here. Genetics. We can't talk about warfarin stability without talking about genetic variations, specifically the CYP2C9 polymorphism.
The role of genetics is really the third dimension of variability here. I mean, warfarin dosing is notorious for being unpredictable. And these polymorphisms, these slight variations in a person's DNA that change the shape or efficiency of an enzyme, they explain a huge piece of that puzzle.
So what's the specific variant that matters most in this interaction?
We focus on the CYP2C93 allele. It's a tiny substitution, IL-359 Lu. Think of it like a slightly different engine part in your metabolic machine. If you carry this variant, your CYP2C9 enzyme processes S-warfarin much slower, your slow metabolizer, so that already puts you at a higher intrinsic risk for an INR spike even before you add a second drug.
So how does the statin interact with this slow engine variant?
And this is where it gets really interesting because the interaction is differential. It's not the same for all statins. For the lactone forms of atorvastatin and lovastatin, the inhibitory potency was found to be stronger, about twofold greater, against the variant CYP2C9.3 enzyme. So in people with this variant, the drug interaction risk is theoretically even higher.
So if you're a slow metabolizer with that genetic variant, taking atorvastatin theoretically makes you doubly susceptible to an INR spike. What about Fluvastatin, the one we already flagged as a problem?
And this is the twist. The reverse was true for Fluvastatin and pitavastatin lactones. Their inhibitory potency was found to be weaker, up to 7-fold weaker in the case of fluvastatin acid, against the CYP2C9.3 variant. So if you're a slow metabolizer, those statins actually inhibit your slow enzyme less.
That is completely counterintuitive. Why would the same genetic variation that slows metabolism for warfarin itself suddenly make it harder for fluvastatin to inhibit that enzyme?
The explanation probably lies in that change in the enzyme shape. The IL-359 Lu substitution is thought to expand the size of the substrate binding pocket on the enzyme. For atorvastatin, that new, bigger shape might be a perfect fit for inhibition. But for fluvastatin, that expanded pocket might make the fluvastatin molecule bind less tightly, reducing its inhibitory power, but only in that specific genotype.
This incredible molecular insight is crucial for individual risk. But what's the practical consequence? Do all clinicians need to start sequencing their patients' genes?
Not routinely, no. The clinical impact of these microscopic interactions, it may be limited for the average patient, but this molecular knowledge is crucial for managing that complex outlier. If you have a patient who is a known carrier of the CYP2C93 allele and they are just struggling with unpredictable INR, knowing that atorvastatin might be making it worse or that switching to pitavastatin might actually reduce the interaction, that provides a whole new layer of understanding.
That has been a deep, deep dive into VKA interaction. But as you said, the standard of care for new anticoagulation is shifting fast towards DOACs. Does this entire complex conversation about CYP450, enzyme inhibition, and INR stability even apply anymore?
This is where the story shifts dramatically and the results. Well, they become initially very confusing. So, direct oral anticoagulants, apixaban, rivaroxaban, dabigatran, and edoxaban, they operate differently from warfarin. They target single factors in the clotting cascade, their metabolism is simpler, but they are also co-prescribed with statins at staggering rates. Atorvastatin and simvastatin are the most common.
So just based on the drug's known profiles, would you expect an interaction? Is it biologically plausible?
Oh, absolutely. The biological hypothesis for an interaction that increases bleeding risk is very strong. DOACs rely heavily on two major clearance systems: the efflux transporter P-glycoprotein, PGP, which pumps drugs out of cells, and they're metabolized by the cytochrome P450 system, specifically CYP3A4. And since both atorvastatin and simvastatin are known PGP competitors and CYP3A4 inhibitors, the theoretical prediction is clear. They should increase DOAC blood levels and potentially increase the risk of bleeding.
Okay, let's look at the guidance for one of the most popular pairs, apixaban or Eliquis and atorvastatin. What's the consensus there?
The guidance is generally pretty reassuring. Atorvastatin is classified as a moderate CYP3A4 inhibitor, which means co-administration may increase apixaban exposure, but the magnitude of the interaction is considered mild. Atorvastatin might slightly increase apixaban blood levels by, say, 10 to 20%.
Is 10 to 20% enough to require dose modifications? Because that would add a lot of complexity.
For most patients, no. The clinical recommendations all pretty much agree that this mild interaction is not considered clinically significant enough to require dose adjustments. The benefits of treating the patient's conditions, preventing clots, lowering cholesterol, are seen to outweigh this minimal risk. Apixaban dose reductions are really only for co-administration with strong dual inhibitors, a category that atorvastatin just doesn't meet.
So theory and regulations say the risk is low. But we need to look at the real-world data, especially this massive cohort and case crossover study that looked at DOACs with both atorvastatin and simvastatin. And this study delivered conflicting results. Let's start with the long-term cohort finding.
Right. So the initial cohort analysis was designed to look at the long-term sustained risk. They compared hundreds of thousands of patients taking DOACs plus the potentially interacting statins, Warfarin-Statin and Fluvastatin, against patients taking DOACs plus statins that weren't expected to interact, like Pleiotropic or Reconciling. And the results were highly reassuring.
What did they find regarding that long-term risk?
They found no evidence of an increased risk for either safety outcomes, so no higher rates of major bleeding, or for effectiveness outcomes like stroke or heart attack. The risk ratios were basically identical between the groups. So this finding strongly suggests that whatever mild pharmacological interaction exists, it just doesn't translate into a significant long-term clinically relevant risk.
Okay, so the long-term data says don't worry. But the same study's case crossover analysis painted a much more alarming picture of short-term acute risk. Can you explain how that case crossover design differs and what it revealed?
The case crossover design is really powerful because it uses the patient as their own control. It compares an individual's drug exposure just before an adverse event, say in the first 30 days of treatment, to their exposure at an earlier, safer time, like 3 months before. So this eliminates all the time invariant confounders. Chronic disease, genetics, lifestyle, everything that doesn't change over time is neutralized.
And what did that methodology find when it looked at statins and DOACs?
It revealed a really striking pattern of what they called temporal vulnerability. The odds ratios for severe safety outcomes, bleeding and mortality, were significantly and dramatically elevated, but only among those patients who started a DOAC while they were already taking the statin.
Give me those numbers. We need to emphasize just how big that risk was in that vulnerable window.
They were catastrophic. For patients initiating a DOAC while they were already stable on atorvastatin, the odds ratio for serious other bleeding was 5.06. If they were on simvastatin, the ORs jumped even higher, 6.05 for GI bleeding and an astonishing 6.81 for other bleeding. I mean, an odds ratio of nearly 7 times higher than the reference period suggests a massive acute risk spike right after that DOAC is introduced.
A 6- or 7-fold increase in short-term bleeding risk. That seems to confirm the biological hypothesis, right? That the statin is spiking the DOAC level and causing a crisis.
This is the critical, mind-bending twist in the whole thing. The high risk of bleeding and mortality was not observed when the statin was started after the patient was already on the DOAC. So if you started the DOAC first, adding the statin later was safe. And here's the real kicker. Similar, highly elevated ORs were seen when initiating DOACs while taking other statins like Fluvastatin, Pravastatin, or Rosuvastatin statins that are not known as strong CYP3A4 inhibitors.
Wait a second. If the risk isn't specific to the CYP3A4 inhibiting statins, and it only uses when the DOAC is started second, that suggests the statin itself is not the pharmacological problem. It suggests the timing is the problem.
That is the profound conclusion the researchers drew. This critical distinction implies that the high risk of bleeding and mortality is not due to a specific drug interaction mechanism. It's not about CYP3A4 or PGP. Instead, it is likely a powerful marker of temporal clinical vulnerability.
Temporal clinical vulnerability. So you mean the patient's underlying health was just severely deteriorating around the time the DOAC was started, and the statin was just an indicator of their pre-existing fragility.
Exactly. If a patient was already stable on a statin, it means they had severe underlying cardiovascular disease. The urgent addition of a DOAC often signals an acute deterioration, a new diagnosis of atrial fibrillation, a new VTE, something that has dramatically increased their stroke risk. The adverse events just clustered around that period of intense underlying clinical instability, regardless of which statin they were on. The statin was just a flag waving to indicate the patient was already desperately fragile. It wasn't the primary cause of the bleed itself.
That completely reframes the clinical conversation. So the implication for practice is not about which statin to avoid with DOACs, but is an urgent warning to clinicians. When you start a DOAC in a patient who is already on a statin, you have to be hypervigilant because you are dealing with a demonstrably fragile patient who is at high acute risk, independent of the drug's specific interactions.
That is the core takeaway for DOACs. The evidence gives us long-term reassurance, but it sends a powerful, immediate signal about short-term patient vulnerability right at that initiation phase.
So we've covered the risks, the manageable pharmacological competition with warfarin, and this circumstantial clinical vulnerability with DOACs. Now let's pivot and address the other half of the equation, the profound benefits. Because statins aren't just potential competitors, they're actively affecting the clotting system in ways that often make their co-prescription a secret weapon.
This is truly the most optimistic and I think maybe the most revolutionary part of statin research, the pleiotropic effects. These are the non-cholesterol-lowering beneficial actions that give statins their own intrinsic antithrombotic properties. And crucially, these effects are rapid. We see them fully realized within just 1 to 3 days of administration, long before cholesterol levels have even started to drop.
That rapid onset is so key. It proves these effects are totally independent of their main job. So let's look first at how statins directly interfere with the core coagulation factors, acting as their own kind of anticoagulant. Where does that process start?
It begins right at the starting line of all blood clotting, with tissue factor, or TF. TF is the primary initiator of the entire coagulation cascade. It's usually only exposed when a blood vessel is injured. Statins act as a powerful brake on this process.
How do they do that? How do they downregulate the core initiator?
They achieve this by inhibiting the aurorokinase pathway. This is a signaling pathway that's entirely independent of cholesterol metabolism. Research has shown this inhibition dramatically limits how much tissue factor the endothelial cells and inflammatory cells express, and clinically, the impact is immense. Studies looking at atherosclerotic plaques found that atorvastatin users had 29% lower TF antigen levels and a staggering 56% lower TF activity compared to those on placebo.
56% lower activity. That is a massive reduction in the ability to even start a clot.
It's an incredibly potent effect.
So what happens further down the line once the cascade is initiated?
Downstream, the second crucial target is the main enzyme that actually generates the thrombosis, thrombin. Thrombin is the molecule that drives the final formation of the clot. And numerous studies consistently show that statin therapy results in decreased thrombin formation.
How significant a reduction are we talking about?
In high-risk patient populations, studies have shown a significant reduction in total thrombin generation, ranging from a 16% to a 40% reduction. And again, we have to reemphasize, these dramatic reductions were totally independent of the patient's lipid levels. By reducing the overall generation of thrombin, statins basically lengthen the initiation phase of blood coagulation, giving the body more time to break down a nascent clot before it fully stabilizes.
So the central engine of clotting is slowed and weakened. What are the cascading effects on the rest of the fibrin and factor production?
The downstream effects are pretty comprehensive, and they're all aimed at weakening the clot structure and promoting its breakdown. First, on fibrinogen. Statins impair its cleavage, so the building blocks of the clot are less efficiently activated. Secondly, they increase the permeability and lysability of the fibrin clot, which essentially makes the clot structure looser and more susceptible to natural breakdown.
And what are the cofactors and stabilizers that make the clot strong?
Statins reduce the formation and depletion of factor V, FVA, which is a critical cofactor needed for thrombin generation. We've seen that reduction within 3 months of starting simvastatin. Furthermore, they cause a reduction of factor XIII activation up to a 20% reduction. Factor XIII is the glue that cross-links the fibrin strands to stabilize the clot. So reducing its activation means the resulting clot is structurally weaker.
That's a remarkable collection of actions. Inhibit the start, reduce the central enzyme, and weaken the final structure. Is there any factor that promotes anticoagulation that statins actually enhance?
Yes, and this is the final, really elegant piece of the puzzle. Statins enhance the expression of thrombomodulin, or TM, on the surface of endothelial cells. TM is vital because it's an internal regulator. It forms a complex with thrombin that effectively converts that thrombin from a powerful procoagulant enzyme into an anticoagulant enzyme. It's an internal switch driven by the statin that flips the powerful thrombin from working against the patient to working for them.
That covers the direct effects on the coagulation cascade. But statins also have this secret life as an antiplatelet agent, complementing the direct anticoagulant action. How do they affect the platelets?
They exert significant antiplatelet effects, which are particularly important in preventing arterial thrombosis. They primarily work by enhancing the anti-aggregatory signals.
Specifically, which signals?
Well, they strongly enhance nitric oxide NO synthesis and activity. NO is a powerful vasodilator, but its increased availability also acts locally to reduce platelet activation and aggregation. Secondly, statins inhibit the formation of thromboxane A2, which is a powerful chemical signal platelets use to recruit other platelets to the site of injury.
And do they interfere with the signaling molecules that platelets use to communicate with the vessel wall?
Absolutely. They actively downregulate several potent platelet agonists and receptors. This includes things like CD36 and the lectin-like OXLDL receptor 1, and they also crucially inhibit the CD40 ligand, which is a major inflammatory and prothrombotic signal produced by activated platelets.
So we have this profound dual action, an intrinsic rapid anticoagulant property and a coupled antiplatelet property. What are the concrete clinical implications of all this pleiotropy? Does it translate into measurable reductions in things like VTE, the venous events that anticoagulants are prescribed for?
The clinical evidence for thrombotic risk reduction is compelling and often surprising. This dual action is why we see these significant benefits that are totally independent of lipid lowering. The Jupiter trial is the classic example. It reported a striking 43% reduction in the first episode of venous thromboembolism, VTE, in rosuvastatin users. That number of 43% reduction in VTE just from a statin shows the massive power of these pleiotropic effects in reducing venous clot formation.
If statins are providing this potent, rapid antithrombotic boost, that makes the question of major bleeding risk even more crucial. If a patient is on a VKA or DOAC, and a statin, which has its own antithrombotic properties, is the bleeding risk significantly compounded?
This is the dilemma, and it's why the data remains conflicting, which creates uncertainty. On one hand, the Sparcell study, which used high-dose statins for stroke prevention, did observe an increased risk of hemorrhagic stroke in statin users. That's the watch out for bleeding warning. But then you have these massive studies like the heart protection study, which found similar rates of hemorrhagic strokes in statin users and non-users. So the data pulls in both directions.
So how does the medical community synthesize that conflicting data? Does the benefit of VTE prevention outweigh the potential, though inconsistently proven, risk of hemorrhagic stroke?
The synthesis suggests that the protective effects are robust and broadly beneficial, particularly in reducing VTE recurrence and overall mortality in high-risk patients. So while the baseline bleeding risk is real and you have to monitor it, the intrinsic antithrombotic properties of the statin are often seen as complementary. The resulting overall net benefit is often positive, provided that initial clinical vulnerability, which we talked about with the DOACs, is carefully managed. The conversation shifts from, does the statin interact dangerously, to, does the statin contribute meaningfully to my overall protective strategy?
This has been an incredibly detailed look at a common drug combination that is anything but simple. Let's synthesize these major key takeaways for everyone listening.
Okay, so if we synthesize this complex landscape, the relationship between statins and anticoagulants is really defined by two distinct, powerful, and often counteracting forces.
First, there is that measurable, manageable pharmacological competition, which we see most clearly when we're dealing with traditional DKAs like warfarin.
Right. That specific drug interaction is real. It happens predominantly via CYP450 and CYP2C9 inhibition, which is why statin selection is so critical, right? Avoiding fluvastatin, preferring atorvastatin or pitavastatin, and it demands strict adherence to monitoring protocols. Checking INR at 1 week and 4 weeks to catch that peak, the risk is predictable, and it's entirely manageable if you follow the protocol.
And second, there's that powerful non-pharmacological clinical vulnerability that we uncovered when analyzing the newer DOACs.
Absolutely. The large case crossover studies prove that the terrifyingly elevated risk of short-term bleeding and mortality is not due to a metabolic interaction between the DOAC and the statin. Instead, it is related entirely to the timing of drug initiation. It's marking patients who are so fragile they need the urgent addition of a DOAC. The statin is just a marker for that underlying acute clinical risk.
So whether you're managing VKA or DOAC therapy, the ultimate mandate is one of precision in monitoring and statin selection for warfarin users, and precision in clinical assessment of patient fragility during that initial phase of DOAC therapy. It's about optimizing the benefits while minimizing these complex risks.
That is the encapsulation of the data, and this entire discussion leads us to a fascinating final thought for you to reflect on.
Given the clear and potent evidence we discussed, that statins exert these immediate non-lipid lowering effects on tissue factor, on thrombin generation, and on platelets, effects that are consistently and powerfully antithrombotic and protective. Does the current clinical framework adequately distinguish between the statins we prescribe for cholesterol lowering versus those we might in the future prescribe purely for their immediate pleiotropic antithrombotic properties in high-risk patients, irrespective of their LDL levels?
It's a question that really challenges the entire traditional role of statins. It opens the door to an entirely new therapeutic indication, one driven by their powerful secret life inside the clotting cascade.
A perfect note to end on. Thank you for joining us for the deep dive. We hope you feel thoroughly well informed.